Hi, I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Long Tu, an assistant professor of radiology at Yale Medicine, and he'll be discussing with us his recently published AJR article on the imaging evaluation of patients with dizziness. Dr. Tu, thanks so much for joining us.
Hi. Thanks, Dr. Rosenkrantz. Thanks for the opportunity with AJR, and I'd be happy to discuss this paper and its implications for clinical care.
To start us off, what are the current challenges in the imaging evaluation of patients presenting with dizziness?
All right, thank you for the question. So, dizziness has been long recognized to be a challenging scenario in emergency and acute care. Most frequently, and this has been written about a lot in the radiology as well as the emergency medicine literature, is that when patients come in and there's a suspicion for an underlying abnormality or a central etiology for dizziness or vertigo, the most available and most commonly used sort of studies is CT or CTA, either alone or both together. And if there is an underlying stroke, which is often in the posterior circulation of the brain, CT or CTA is often not very sensitive to pick up the underlying stroke. Even conventional MRI is imperfect. It may miss up to 20% of strokes. And even in patients where, let's just say a patient has had a stroke, but they're not a candidate for thrombectomy or thrombolysis, like an acute management, finding the underlying diagnosis, why the patient is having dizziness or vertigo, really impacts long-term outcomes through secondary preventative measures for stroke. So if we can detect that stroke, that really helps. Because of the limitations of currently available approaches, finding new ways to approach patients with dizziness and get better sensitivity for underlying stroke is going to help us do better patient care.
To address this question, this study used propensity score matching. Can you explain this technique to us?
Yeah, it's a great question. So this is oftentimes an under-leveraged technique to help compare patients who have received one intervention or another. So in a big picture sort of way, if we're trying to compare patients who have either received one exposure intervention or another, if you just compare an aggregate, it's not necessarily a fair comparison, right? Because those patient groups may be different. And often in medicine, the ideal would be to do a prospective, randomized, placebo-controlled study to sort out what effect is really attributable to the difference in care. Like, for us, it would be, or in this paper, it would be, whether a patient had received an MRI or they had received, if they had received a presumably reassuring CT with CTA. Okay, so that would be the comparison. We want to figure out what's the difference between those two groups. And if we compare just an aggregate, those patient groups might be different. So we might not really be sorting out the difference that's attributable to MRI use. What propensity score matching does is really allow us to find groups that are really similar within these I guess we should say subgroups that are very similar within the groups that received either CT with CTA in a mid-discharge or had received some MRI during the course of their care, as opposed to methods that are often used in the literature like regression analysis. What we've done here, and with propensity score matching, you can get a perhaps more powerful control for all the potential confounders. And of course, it's a quasi-experimental method, so we're not actually doing something prospective. We're looking retrospectively at data and doing a high dimension kind of way of looking at patients who could be similar and then matching them up and then trying to make that comparison between those similar patients. So it basically helps us do a better comparison to understand the impact of an intervention.
And can you explain further what were the two actual groups that were compared in this study?
Oh, absolutely. So what we really wanted to get at is that currently many patients may show up at an emergency department, be evaluated for potential underlying etiologies of dizziness, and a lot of times such patients, because the availability of CT and CTA neuroimaging, they're evaluated by that. Other workup is either reassuring or points to a peripheral cause, and these patients are ultimately discharged, right? We wanted to estimate the potential value or the impact on management outcomes if those patients who had otherwise, had reassuring CT and CTA imaging, if those patients instead had received an MRI during the course of their acute care. And so the groups that we chose here were patients who were evaluated for dizziness, had received CT and CTA, and then were discharged. So that was like our control group. And then we took those patients and we found very similar patients, as similar as we could, who arrived at the ED, were evaluated for dizziness, and at some point during their emergency care received an MRI. And among those that received an MRI, they were allowed to maybe have also received some sort of CT imaging. They could have been discharged, they could have been admitted, but they were similar in their patient characteristics to groups that were discharged after presumably reassuring CT and CTA.
And what were the factors that you used to make sure they were similar, that you used for the propensity matching?
Yes. And I should leave with the caveat that this, as a kind of statistical method, there will always be, as compared to prospective randomized trials, there is always going to be a potential for some residual confounding when you try and control for as many factors as possible. But the nice thing about propensity score matching is it allows you to, in such a way, use a large number of factors. So we used patient demographic factors, age, not just so they came in with a chief concern of dizziness, but we also allowed them to be matched on concurrent other chief concerns such as dizziness, nausea, headache, other sorts of things, review of systems findings, physical exam findings, including their vitals, and many other sort of, and all these together. And I should also mention that we had their NIH stroke scale, and their GCS, all these various data points that all together, hundreds of them, can help us match patients to make them look as similar as possible when we're comparing. And then these were ultimately, these factors were kind of honed down to find the most important ones through a selection process, and then patients were then matched on those.
So how big were the groups before and after the matching?
Perfect. So in the primary analysis for this paper, the first analysis, patients that had received a CT and CTA and then were ultimately discharged, that group before matching was a little bit more than 700, and among those that had received some MRI, it was a little bit more than I think 1,100. And then when we matched them together, we ended with a group of just over 400, 407, and so what we're really doing is we're finding the similar patients in each group, and we're saying among those patients who were similar, could have received one or the other based on their characteristics, what is that difference in that subgroup? So it doesn't apply necessarily to all patients who had received one or the other.
So what did you find in terms of your primary outcomes?
It's a great question. Ultimately, the major findings of our work here are that if a patient had received MRI compared to one had been discharged after CT, CTA, the patient was more likely to have had an abnormal or a critical result on their neuroimaging, to have more likely to have initiation, change, or increase in their medications used for secondary prevention of stroke. They were more likely to have received a subsequent echocardiogram evaluation for central or cardiac, potentially for cardiac etiology or of emboli, and then we also looked at 30 and 90-day return rate to the ED. So in the primary analysis, those were not significantly different. But the other preceding ones that I talked about, those were all different between the two groups.
So there was also a secondary propensity score analysis. Can you tell us more about that and what it showed?
Yeah, perfect. So in addition to conventional MRI, which is imperfect, as we talked about, it's going to miss 1 in 5 underlying posterior circulation strokes. But there have been new techniques described in the literature over the past 5 to 10 years that suggest if we use high resolution DWI as part of an MRI protocol, that we can detect more strokes, and that the sensitivity can be upwards of 90, even 95% sensitive rather than only 80% sensitive. And not only can we get greater sensitivity, but what we can do is kind of hone our MRI protocols so that they are abbreviated and really are only include sequences that really help us detect that stroke, and are kind of don't include sequences that maybe are for other indications or more useful for other indications. So what we have also done is that we have a subgroup of those who received MRI who received a what we're calling here, or referring to as a specialized abbreviated MRI, right? So it's going to be more sensitive. It's presumably going to do all the things that regular MRI does, except it's easier to access and it's more sensitive, right? So we did what's basically like an analysis using a subgroup of those who received MRI. We compared those also with patients who were discharged after CTA. This was a smaller group, so it was 100 patients that were compared. But ultimately, all of the the primary outcomes in terms of critical abnormal imaging findings, secondary preventative measures, those were also different. Those were increased with the use of the specialized abbreviated MRI protocol. But then also patients had decreased 90-day readmissions to the ED. And we're thinking it would be the kind of potential or suggested mechanism here is that with greater sensitivity of picking up an initial abnormality, an initial stroke, we're getting patients to better secondary prevention, getting patients the appropriate care for the appropriate diagnosis, and they're not returning back to the health system for repeat episodes of acute care.
Great. So based on the findings, what do you recommend for clinical practice?
Yeah, so this is the first of potential greater look at this in the literature with follow-up studies. So definitely this, what we're finding here needs to be replicated and understood in different settings. There are caveats to what we've done here, but what our results are very much concordant with what you might expect given the current state of the literature in this area. And that, altogether, this in our work suggests that at institutions in settings where we do have access to some sort of MRI, patients who come in with dizziness and it's not clear what's going on. And let's just say they're not acute stroke treatment candidates, but we need a diagnosis, and maybe we are looking to exclude stroke, or we're looking to mitigate against the outside chance of a subtle underlying stroke. If we have access to MRI, it's preferable to use MRI in these patients, either as a standalone exam, if there's not, if we're not concerned about, again, acute or large vessel abnormality. We want to prefer MRI compared to the most commonly used CT or CT to CTA evaluation. If we have access in these protocols to get higher sensitivity and more access through abbreviated protocols, if we have access to a specialized or abbreviated protocol, and these can be built, they're described in the literature, this would provide probably even greater sensitivity detection of stroke and may have downstream benefits in decreasing returns to the ED. And of course, more work needs to be done in this area, but I think this could be a promising way to address truly one of the most widely recognized and kind of serious issues in terms of diagnosing stroke appropriately in our acute care centers.
Any key limitations to mention?
Oh, absolutely. So I think the key thing that we need to mention here is that this is, we are looking at a single institution. This applies only to centers that have access to MRI, right? So we can't apply these to places where there's this was done at a place where MRI was not necessarily in the emergency department, but it was in the same campus, and you had to be transported. Patients had to be transported to and from the ED to get that scanning done. But not all places have that functionality. And then also there are some limitations with regard to doing a retrospective study and looking at an observational cohort of patients. And there could always still be residual confounding. We included as many factors we could to mitigate the potential, but if these results were replicated in other settings, and then seen also in a future prospective work, it would further improve the kind of confidence in our findings. And I'll just say one more big picture sort of thing is that the ultimate cost effectiveness of this sort of work, or the viability in terms of a workflow or logistic standpoint, is not, the broad implications are not yet known. And so it could be the case that catching more strokes early and preventing long-term sequelae is ultimately, we suspect that is useful from a broad health systems perspective, but this is not yet known also. So there's still quite a bit to be done and to understand how these specialized protocols and these various different strategies of approaching dizziness, vertigo, potential posterior circulation stroke, how this all fits together and how this can be done to better take care of these patients.
And any final takeaway for our audience?
I think, I very much appreciate the work that AJR does in helping bring this sort of work into the broader understanding of our imaging and medical community. We have had, this work is coming out at a time where, a recent large systematic review in emergency medicine has found that missed stroke is the leading cause of preventable harm and disability in acute care. And it's coming out after the recent release of GRACE 3 guidelines to recommend differing and more sophisticated approaches to acute dizziness and vertigo in the emergency departments. I think that this is an area that is increasingly well understood. I think that approaches may, in different institutions with different resources and different institutional ability to do either bedside risk stratification or provide specialized imaging approaches. I think there's going to be a variety of approaches to doing better. And I think it's just, I think that as we continue to work in this area and many people put their efforts together, I think, it's just a great opportunity that we can reclaim the value that we give to patients by making kind of more accurate diagnosis in this area. And I think that this is just kind of the first step in a series of advances that are going to make a big difference in this area. So I just want to thank you, Dr. Rosenkrantz and AJR, for providing us a venue to take that, help take that next step for this area.
Dr. Tu, I really appreciate your coming here and sharing your insights with us.
All right, it's been a pleasure until we speak again. And again, thank you to the AJR for this opportunity.